Dr. Sridhar Pilla, DNB General Medicine, consultant physician. So today I am going to discuss about latest update in hypertension. As per the WHO, nearly 63% of the total deaths in India due to non-communicable disease, out of which 27% are attributed to CVD. Rise in blood pressure is the most important risk factor for CVDs. Blood pressure remains poorly controlled due to lack of awareness about hypertension, lack of appropriate care at the primary care, and very poor follow-up of the patients. In India, prevalence has gone up in last 30 years to 38% in men and 32% in women, whereas it was previously it is 29% in men and 28% in women. Despite of that, half of the people they doesn't know that they are having hypertension. In that, people who knows that they have hypertension, they are not getting treated for the same. So even though patients getting treatment for the hypertension, there doesn't, most of the people there doesn't have a optimal control of the blood pressures. So this is the one of the problem that happens in India. And International Society of Hypertension has released ISH 2020 Global Hypertension Practice Guidelines. It categorized into two treatment paradigms. One is optimal control, another is essential treatment paradigm. Optimal care refers to the evidence-based standard of care, whereas essential standards refers to the minimal standards of the care. Usually optimal will occur at where we have a good resources, whereas essential happens at the when we have a very low resource setting conditions. AHA-ACC has released scientific statement in 2021 offering new guidance for the management of stage 1 hypertension among the patients with people with low ASCVD risk. So in this kind of adult with the stage 1 hypertension, that is systolic blood pressures between 130 to 139, diastolic blood pressures between 80 to 89 mmHg. Initially, with very low ASCVD risk patient adult with stage 1 hypertension, initially we'll go for the non-pharmacological therapy and we'll monitor the patient blood pressures for next 3 to 6 months. If it is very well controlled with the non-pharmacological therapy, then we'll go with the non-pharmacological therapy. If it is not controlled even after 3 to 6 months of the non-pharmacological therapy, then we'll go for the pharmacological therapy for these patients. One important concept here is acute respiratory distress syndrome. So usually after COVID-19, most of the people has aware about ARDS. It is COVID-19 is associated with the ARDS. So it is a very potentially fatal condition involving the lung damage. So one recent study from American College of Cardiology reports that metoprolol can reduce risk of inflammation and improve respiratory function in people with COVID-19 induced ARDS. One more important concept here is lowering systolic blood pressures between 110 to 130 range has substantially reduced the CV adverse events in STEP randomized control trial. It has shown that very good control between 110 to 130 mmHg of the systolic blood pressure have a very good cardiovascular outcomes. And one more important concept here is with regard to the prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure monitoring. When compared to the office settings, ambulatory or that is high 24 hours and nighttime BP measurements are associated with greater risk of mortality and composite CV outcome. For every 20 by 30 millimeter increment in the blood pressure at night has a high risk of mortality, that is 23% increased risk of mortality and 36% increased risk of cardiovascular events. So we should have a very good 24 hours and nighttime blood pressure control should be happened compared with the office side blood pressure monitoring. And one more important thing is most of the patients with hypertension, they require lifelong medical therapy. It's not like a dengue fever or malaria. Very short treatment won't be happen for the hypertension diabetes. They need a long-term therapy. The 2018 European guidelines equally recommends for the 5 classes of anti-hypertensive drugs. So each class has its own advantage. So these guidelines recommends equal importance for the all classes of drugs. It also recommends that initial dual fixed combination of AC inhibitors or ARBs with CCB, that is calcium channel blocker or diuretic. So we can initial dose also we can start with the dual combination drugs. Here one more very important change happened was since early July 2018, products containing valsartan have been recalled worldwide. The reason behind this is detection of the known carcinogen, namely NDMA, that is N-nitroso-dimethylamine. So this was the carcinogen found in candesartan, irbesartan, losartan, olmesartan, and valsartan. So this was recalled worldwide. And here is the one very important concept that we are following most of the time. So the HYGEA study, these studies regarding the nighttime antihypertensive treatment. So this study represents that largest study that tested for the nighttime antihypertensive treatment. Already previously discussed that night high blood pressures have a poor outcome, CV outcome. So nighttime treatment definitely will have a improved cardiovascular outcomes and mortality. So these are the new guidelines happened that was discussed now. So thank you very much.